Boy, I love being the guy between this audience and lunch. So here we go. Who's that guy? It's a pleasure to be here in San Diego today. Great city. We feel very safe and protected around all these aircraft carriers and destroyers. I just wanted to say thank you and put a special shout out to Dr. Garrison Bliss, who's in the front row here, the founder of DPC. I wouldn't be here without Dr. Bliss, and I don't think many people in this room would be here without Dr. Bliss as being a pioneer. But I'll tell you a little bit about the journey that I've had with DPC, and I am a DPC patient, and I had a special journey this year too, on a personal level. But we started this effort when Garrison and Norm Wu, his CEO at Q Alliance, came to me in 2009 as the Affordable Care Act was steamrolling through Congress and very eminently going to pass, and would have set up a situation in our country where all primary care was going to have to be purchased through an insurance plan. And Dr. Bliss is in Seattle with this model Q Alliance, and they're saving 20% of the total cost of care for unions and other workers, and providing this amazing health benefit for, what was it, $60 a month, something like that back then. And he said, well, we got to stop this Affordable Care Act thing because it's going to wreck this. It's doing really well, so we got to stop it. And I said, at the time, well, I don't think we can stop it, but what if we could amend the Affordable Care Act to say if you had a direct primary care doctor like Dr. Bliss and Q Alliance, that they could work with the qualified health plan together to deliver a benefit where the essential health benefit included primary care, but the primary care was paid for directly to the doctor through a DPC arrangement. And that's exactly what we did. And we'll talk about that in a little bit, but you can see the growth. This is Phil Eskew's DPC mapper, which we have on our website. It shows the growth of this. This is up to 2,100 practices by count. We believe there's probably many more that haven't been identified. This is up from what we found about 100 when we put the coalition together back in 2009, right? So this might not be, growth through the stratosphere like somebody like CMS or Aetna would want to see, but it's pretty amazing steady growth. And look at all the lives and the care that's being provided here. We have practices like in my city of Washington, Dr. Marguerite Duane, who I think has 40 patients and has a house call practice and sees patients in a neighborhood around DC. And we have practices as large as One Medical Group, and Mark Tomasulo is walking around here today, which is committed to doing DPC as a part of One Medical and others. So there's a lot of different shapes, sizes, and colors of DPC, but they're all, you know what they are. I'm not going to spend a lot of time telling you what it is. But what we've managed to do over the years with regard to policy is come from a place where we had to spend a lot of time bringing people into DPC to explain, what is this? What is direct primary care? And when you talk to a regulator or a legislator, what do you think after you've done that explanation with Dr. Bliss or a group of doctors that come in from your state? What do you think the first question we get from a staffer or a member of Congress is about DPC? Any guesses? Blurt something out. Those are like 2, 3, and 4. The first one is, how do I get this? So, I think we've done a really good job at doing two things. One, keeping this very bipartisan. So, we're going to talk about a bill that's moving through Congress right now. The lead sponsor in the House is Representative Earl Blumenauer, a Democrat from Oregon who is the chair of the Cannabis Caucus and the Bicycle Caucus. And the Republican sponsor in the Senate is Dr. Bill Cassidy, who is a conservative Republican senator who's a gastroenterologist. See, even the gastroenterologists like DPC. So you've got this entire broad spectrum of people, all the way from Bernie Sanders to Ron Paul, that all think, hey, this is a good idea. We try to get this for our patients, regardless of who the payer is. So, the DPC rules in the in the ACA really do a fairly decent job of separating them. This is primary care. It can be paid for through the primary care, direct primary care medical home. This is the insurance. It's over here. And so there is that ability, and I think Dave Contorno and other brokers will say that when we put this provision in the Affordable Care Act in 2009, it was a light bulb to employers. Employers said, I can meet the essential health benefits requirements and offer this great direct primary care benefit, and I can reduce my exposure to these downstream expenses here and offer my employees a benefit that they really want and is going to really provide them with better care. And who wouldn't want their doctor's text information or cell phone number, so they can call anytime they have a question? I think it's certainly better than AI or Google, even though we're going to be using those as tools, as we've heard in the other things. But I'm so excited to hear about the growth in the last panel among employers. And employers are really driving this growth. And there's a few roadblocks that are in the way that we're still working on. So I'm going to talk about 3 pieces of legislation that are actively moving through Congress right now. And when I say actively, I mean literally this week. I'm pretty excited to announce here that the Primary Care Enhancement Act, which is the bill that would clarify that DPC is in fact compatible with HSAs, is scheduled to have a markup, which is a consideration in the Ways and Means Committee. We were hoping it would be either this week or next week. It's likely to be a little bit after that, because you've been watching the news. There's some people in Congress that are thinking about maybe shutting down the government or not shutting down the government. So in the meantime, there's some things that are on the calendar that that they're being postponed and not indefinitely. But the other one I wanted to talk about, so there's sort of 3 things we have here. Let's make DPC compatible with HSAs. Any guess as to what percentage of employer plans include an HSA in this country? Anybody know? It's about 30, and that's probably a low estimate. But it's roughly a third of all employer-based plans now. So if DPC is fundamentally compatible with a third of employee healthcare benefits, it's not a good thing, right? Now we've worked on some workarounds. There's some ideas about how to fix this, but ultimately it's a black letter law. The law needs to be changed. And we're moving that forward, and again, in a very bipartisan fashion. In July, Representative Dan Crenshaw, who you might have seen on TV, is a conservative Republican from Texas, put forth a bill to a markup in the Energy and Commerce Committee, which passed unanimously. This was part of 17 bills that were marked up, and only 2 or 3 of the bills passed without a single dissent. So Democrats, Republicans, liberals, conservatives got together to agree that we ought to be able to figure out a way that states can come and offer a DPC plan through their Medicaid agency without having to come to CMS and beg for a waiver. And this is a pretty complicated procedure. So this isn't a mandate that you're going to have to see Medicaid patients or anything. This is simply a piece of legislation that would enable CMS to sit down with stakeholder groups, including DPC and state Medicaid agencies, and figure out, hey, if we were going to do this, how would this work? Perhaps we would have funding flow through the FQHC, the Federally Qualified Health Center, to a doctor who would take care of a beneficiary, so that the patient didn't have to come into the FQHC, but would see a DPC doctor. They had their cell phone number. They had the same kind of a relationship as if an employer would pay for it. So we're really excited to be able to bring DPC into Medicaid. We've worked closely with CMS on demonstrations like this in the past. The direct contracting demonstration, which has become the ACO REACH program, is very DPC-like for Medicare. So we're trying to sort of skin this cat by going to people and saying, look, we can bring DPC to all of these payers, but it's got to look like DPC. It's got to be a monthly payment. It's got to be a payment that really works. And you can't be responsible for a lot of billing and coding and doing the things that you got out of insurance-based medicine to do. So we've accomplished some of that. The quality measures that these programs ask for in ACO REACH, for instance, there's really only 5 quality measures or clinical measures that you're going to follow for a patient anyway. So trying to reduce the burden of these regulatory programs but allow access to this patient population is something we've been working really hard on too. There's a third one that's gotten a lot of attention. Same idea. We're trying to bring it to Medicare, to Medicaid. We're trying to make HSAs compatible with all of these payers. What about the VA, veterans? Wouldn't it be great if all of our veterans could have access to a DPC doc. There's actually a program in the VA that exists called Community Care that allows veterans to go see a doctor outside of the VA system if they're going to encounter a wait or anything like that. I know there's a bunch of veterans in the crowd, and well, you want to go to the VA, or do you want to go to a doctor who's your DPC doctor that you have the phone number for? So this bill would actually, it's a little complicated, it's a little bit further behind the curve. This bill would actually establish a veteran's HSA, and we know, unfortunately, that HSAs now are not compatible with DPC, that then would allow the veteran to pay a DPC doc with. We think that's a great construct. Representative Chip Roy has this. This is a partisan bill at this point, but we think we can bring Democrats along if we maybe broke this off into 2 bites. Let's work on getting veterans the ability to use a community care doctor who is a DPC doctor and get paid for by that monthly fee that the DPC doctor would offer. And then let's work on the HSA later, because we think that's a really good idea, but might take the VA a couple of years to figure out how to do an HSA, where we think the transition to DPC is a natural one for the VA, and they really are, the individual VISNs that run the VA hospitals are allowed to do this now. But this is Congress sending them a really strong sign that they should be able, to do this. So these are all hopping right now. I was hopeful to tell you that the Medicaid Primary Care Improvement Act was going to be subject to a vote on the full House floor today. But again, that shutdown has pushed this off a little bit. But it is actually right now on a calendar in the House for consideration on the floor called the suspension calendar. And what that means is there's a certain number of bills in the House that are put on this suspension calendar. They're voted for up or down. They're considered to be bipartisan bills. Congress would have to pass this with a 2/3 majority, no amendments, up or down vote. We do expect this to happen in the next couple of weeks. We think this bill is going to go through the House, and we're working really closely in the Senate to try to get this thing through. Both of the first 2 bills we think have really good legs for this year. And we're really excited to work with everybody on these things, and we think they are going to be things that really help the movement grow. And the DPC Coalition, that's what we're all about. We want to facilitate building these links to employers by changing regulations and building the networks that allow you to have access to a greater number of patients. It's ridiculous that 1/3 of all employees won't be able to contract with you simply because they have an HSA. The nuts and bolts of that, I think Kenneth talked about this a little bit earlier today, it really isn't a problem for the doctor, it's a problem for the patient. So what the rules say is if you have a high deductible health plan that's tied to an HSA, you can't have another health plan that covers things that would already be in the high deductible health plan. Well, to a de minimis degree, HDHPs do offer primary care. They have AB-rated preventive services and stuff that's covered. We all know that's not DPC. But the IRS has really no choice but to look at this under the current construct of the law and say, we view DPC as a second health plan. This then makes the HSA holder ineligible to fund the HSA. It doesn't mean that they can't have an HSA, they just can't put any money in it. So you're sort of in this catch-22 world where, I can have the HSA, but I can't put any money in it because I have this DPC doctor over here that disqualifies me, makes me ineligible to have the HSA. This law would simply define DPC as a qualified health expense that creates an exception by which it does not make a person ineligible to fund their HSA, even though they have this second coverage or second health plan. So, this has been our top priority for a long time. A lot of Democrats look at the word HSA as a 4-letter word. They don't like it, and we can go into various reasons why later, but suffice to say that there's some partisanship around the HSA concept. We've gotten to the point where Democrats and Republicans all together really understand this isn't about making the HSA better, it's about bringing better health care to the patient. And if 1/3 of all patients have an HSA, you're denying them a benefit that they should be able to access. We talked a little bit about the Medicaid and the veterans. I won't go through any more of that. I want to talk about the other thing that's really moving right now. You've probably all heard prescription drug reform. And this has become increasingly important because I know like as a patient, I've often asked the question, when did prescription drugs become not part of primary care? Well, the reality is they are part of primary care, and we've made really good progress trying to break the hegemony of the PBMs down by saying, look at the alternatives that we have here. I remember a couple of years ago, I took a spreadsheet that Ricky Hogue from Core Primary Care in Pennsylvania put together of the prices that they were offering for meds that they were dispensing directly in the office. And this was in the Trump administration, who really wanted to believe that this was a good way forward. The reaction was, hey, this is fake news. This is not true. These numbers can't be right. I called Ricky and said, hey, are these numbers right? And he said, yes, we're doing this. So we've worked really hard, number one, to show the people doing the PBM reforms do no harm here, don't make any changes that would make us not be able to do this dispensing. We've worked really hard to try to get dispensing done in the only state that doesn't allow it right now, which is Texas. We came really, really close to passing a bill in Texas that would have allowed docs to dispense and would have allowed pharmacies to do pediatric vaccinations. Everybody in Texas thought that was a good trade, but the clock ran out and the whole world blew up over a number of issues, abortion and other things. So, that didn't get done, but I think we're working really closely to do that. Another bill that actually passed quietly in 2013 that a lot of doctors, they're trying to pull me out. A lot of doctors didn't notice, the Drug Quality and Security Act, which is the track and trace rules that pharmacies and health plans have to follow. It is, doctors who dispense are subject to these regulations. And there are fines and enforcement penalties if you don't do the proper tracking and tracing of all the codes of where the drug came from and where it's going and be able to report that back to the government. It's not a big burden, but most doctors don't know they have this. There's enforcement penalties that are going to begin to be levied by the FDA for any problems that might arise from either counterfeit drugs or drugs where there's a problem with interaction or anything like that. So this enforcement has been kicked down the curb since 2016. It was supposed to start in November of this year. There's been one more year granted of enforcement flexibility where they're not going to start looking at individual practices, but this is definitely something that you need to be aware of. And we're trying to help this with this partnership that we've created with Lineal Health and AS Meds. And they're our partner to try to help create a seamless, tailored dispensing program for docs. And there's a QR code. You can learn more about it or go to see the ASM Lineal Health booth back there to talk to folks about it. We've worked really hard at the coalition to try to offer this tailor-made, sort of seamless program to deliver meds that can either be dispensed in states that are not allowed to be dispensed. We have an option to do either a mail order directly to the patient, which is fully compliant everywhere, or they can offer a discount card that you can give the patient, and the patient pays you the $5 for the meds. So we're working really hard to try to grow DPC again by expanding the offerings that are included within primary care, and we think meds are part of it. And we're really happy to be a part of the solution of a future where patients can get meds without having to use their PBM. So really excited to offer this. I know we are right up against lunch. I'm happy to take any questions if people have them, but we're going to go to lunch. Just catch me, and we'll go from there. So thank you very much. It's a pleasure to be here.